So, thank you AIS for giving the opportunity. So I will discuss after these two sessions, cataract challenging case in capsule management. Basically, I will focus on the MSc, intumescent and HMSc. So going to history, 5th century BC, Susruta did the cataract surgery, the couching. And then modern cataract surgery was first done by in France by Jacques Devils in 1748. And they are still, that is ICG. And the 1949 first IOL was invented. Then after that, ECC and FECO, then SICS. Now we are handling with femtology assisted cataract surgery. So I want to say that the capsule management is just like some few years, 70 years back. So what happens in MSc, HMSc or intumescent cataract? They comes with either phacoemorphic glaucoma, sometimes if they present late, phacolytic glaucoma, and there is even difficulty in phacoemulsification, and especially if you are just in your younger age of surgical exposure. Longer surgery time, more CDE, and so more chance of endothelial loss. Capsule laxity slightly difficult, not perfect always, it is chance of always runway. More chance of complication in terms of vitreous loss, granular damage, iridodylis, etc. So first I will come to the case. It is the case when I was a resident some few years back. So you can see that it is a MSc with intumescent cataract. So when I first start, as we trained to do the suction with that needle itself, and after that with cannula. But I want to say that here I could not turn the rexis with the forceps. Why? Because what I have drawn the fluid, it was not complete. It was only from the center 3 mm. You can see there is still the turgidity in the periphery. So if you turn the capsule rexis now, and as I felt difficult, so I removed that, that means the manual rexis forceps. Otherwise it would have been turned. So what I did again, because there was a still turgidity in the periphery, so that was not happening. So I had to make a cut with cystitum. Then you will get a flap, and you can, and you have to repeatedly fill with the viscoelastic, because as this instrument is large, so always the visco is coming out, and your anterior chamber is becoming shallow, and the chance of again the capsule to the periphery there. Then you will do a decent phaco by whatever the means. So another case I want to say, it was our resident doing some 6 months back. This was a case, she was doing SICS, you can see this has shown here. And as this was intumescent cataract, so instruction was to, like that, to aspirate with that cannula only, that cystitum only. Then you will aspirate all the fluid from the periphery also, and from the other side also you will aspirate, so that at least 4 to 5 mm there will be safe zone, the capsule will be not turgid. And then you can see there is slight extension. So now you have to put this with manual rexis forceps. But I want to say that as it is SIS wound, the tunnel is more, the manual rexis forceps, it will not help when you will go to the extreme periphery, because it is very difficult to manage there. In this position, it is very difficult to manage. So I removed the manual rexis forceps here, because it was not getting the sufficient length, and the visco was coming out. So I used the ILM forceps, that is microsis forceps, and we completed the rexis, and it was SIS, so it completed. So these are some tips. So in the next case, sorry. So this was the case, one of the doctor's father was there, and I want to say that as there was no fluid that regressed from there, so I didn't sucked up the fluid, but eventually it got fast, and their capsule was extended, and within few seconds that when I was drawing fluid, it becomes to a like adrenal flag sign. So in this case, what I will do? So because as you told, there will be anxiety, and it is like fathers of a doctor. So it is very, but if you thought before night, it can happen to this type of things, and you have sufficient experience. So After this type of big gap of like Argentina flag sign, so many will do like it will convert to the SICs, etc. So if you have many options, like you have micro scissors, forceps, etc., you can use, and you can do a supracapsular phaco here. So I tried that, and I have to cut this with the scissor. Then you can do this with Rexis forceps. Why I didn't use that micro that is forceps, because there was already lens was coming out, because there was a big Rexis gap, and the micro Rexis forceps, that means manual forceps, when you are entering the visco was coming out, so it is very difficult. So I tried with the, that means 60 term. If it can happen, then good, because it is very less space it will take. So it was happening, I could manage that. But again, I have to cut because it was a large nucleus. So I wanted to make the lens slightly anterior to the capsule so that I can complete the supracapsular, that means phacoemulsification, because there was chance of extension of the capsule Rexis to the posterior might be there. So we didn't want to take chance. So if there may be some endothelial loss, but yes, it is better than the lens drop. So at last we completed the case well, and with intra-back lens implantation. So I want to tell some tips, the helping tools here, because I think many might have not noticed this when you are doing the ultrasound. Ultrasound here, when you will do any mature cataract, that means hypermature cataract intumescence, we do ultrasound to look for the vitreous, no? And sometimes if you see the posterior like capsular component, we want to see the posterior capsule intactness, so that we can assume that there's some complication, etc. But here I want to say that one extra finding you can check here. Sorry, cursor is. This capsule is, this spike, no, this one single spike is collaborating with this capsule, okay? And so that means there is no fluid in the posterior compartment. But when you see this, here there is a double spike. Double spike, one spike is corresponding to the posterior capsule. Here the second spike, that is parallel spike, it's corresponding to the whole nucleus. Okay, so there is the gap in between the two spike. Here you can see that there is liquefied cortex. So if you find this, so you will, that means you'll prepare that posterior interlenticular pressure is high. Even if you withdraw the fluid from the anterior cortex, so there may be still chance. So then you may, there are some other options, like some people do partial vitrectomy limited, some we do like manital before pre-op manital, that will help. Here you can see, just for demonstration purpose, here that is intumescent cataract was there, but all the intumescent cataract will not have the posterior capsular, that means posterior interlenticular pressure, that means compartment fluid. You can see that single spike here. But here another case I want to show that when we did, you can see here there is a two corresponding spike, double spike. It's corresponding to, there is a fluid in posterior compartment is there. So you have to prepare accordingly. Another case, there is phacolytic glaucoma. This patient was, we did surgery at the COVID times because the phaco was not working, our machine. So what we did, the patient when came, like this, patient was with congestion, like corneal edema. So you have to do the ultrasound. Ultrasound, what we got? You can see this, the architecture of the lens has been changed. No? There is two capsules, they have, that means they adhere, like the fibrosis. So from the, before the OT, we could have guessed this happened. So when after just irrigation aspiration, we found like this type of things. So as as machine was not there, so we did later when the just vitrectomy, the capsule we just trimmed with vitrectomy cutter and put the, that means normal, that means sulcus, lens cell sulcus, the vision is 6/9. So what are the precaution and take-home message we should take? Rexis forceps, micro forceps, scissors should be ready and standby, like in this type of cases. Pre-op manital works in reducing upthrust, at least in my cases. Aspiration of cortical material by needle, by cannula, and by sometimes irrigation aspiration bimanual, you can do that. You can start with very small Rexis. After irrigation and aspiration, you can enlarge Rexis. Some people do double Rexis. Some literature, they told that phaco aspiration, direct phaco aspiration of the central capsule and cortex in one go. Then we will, there are detergents, some there is some space you'll find, then you can do the other rexes, next rexes. Backup IOL is must, I will say. That means you multi-piece and rigid is must, because you may sometimes cannot put the multi-piece also if there is a severe capsular problem. And as the first speaker told, pre-op counseling. Pre-op counseling is must. In my cases, I told this patient, I tell patient that we may not put the IOL. Patient has to accept on that day. Yes, you have, I show the photo. You have the, like this type of cataract, it 95% of chance I will put lens, but sometimes you may not, you may secondary IOL you may need, second surgery you may need. So just free up the prime the patient before, so your 90% of tension will be reduced. So good free up counseling is must. Thank you for your kind listening.
Thank you, Dr. Rakesh. Very good presentation. See, with intumescent lenses, actually, I don't worry about them anymore, actually, frankly speaking. Because when you do your manual decompression, the problem with manual decompression, when you're doing manual decompression, both your hands are on the syringe. It's very difficult to control the syringe. When you're pulling, especially when you're pulling, it will move. The very movement will make the thing go away, run into the flag. Okay, having said that, when you get the flag, it's very rare for the flag to go posteriorly. It stops. So you can handle the cataract. When do you extend it? You extend it when you're doing the disassembly of the nucleus. That is when you attempt in the bag on a hard nucleus. So when you have a hard nucleus, change to SICS, or you bring it supracapsularly if you're confident of the endothelium. Or if you're very confident, you can do it in the bag, but you have to be very careful with lateral separation. Soft cataracts, no problem. Another thing, if the tear is vertically, if it's going down, that's another problem. If it's horizontal, no problem, you can manage. So what I do now, in fact, I'm presenting it tomorrow. What I do now is I put my aspiration needle, I connect it to my aspirating line of the phaco machine. So now what you have the needle in your hand. Your left hand is free, your non-dominant hand is free. So you can fixate the globe, or you can inject visco through the paracentesis. Your vacuum is coming from your foot switch. You just press down just before you go into the thing and aspirate. You can stay in as long as you want. You're very stable. And what you were talking about, the phacorexis is also very, very easy to do. You just punch a hole in the capsule, and with the vacuum, you're aspirating some of the cortex. So it decompresses the lens. So what some people, I think Mohan Rajan calls it the phaco punch technique. Then you have the double rexes. There are lots of techniques to do this, but you don't have to panic. An Argentinian flag also he showed you, you can just make a crude rexus and go ahead and do your phaco. Sorry, any question?
Sir, may I add one thing? You showed one case with doctor's father in Argentine flap sign.
Sorry, I didn't get your question.
It's an add-on, sir. With my experience, the case in which he said it's a doctor's father with Argentine flap sign, instead of doing with the help of 26 gauge needle, there are two types of rexus forceps. Which one he mentioned has got a large diameter. So obviously if we put it inside through the main port, obviously the viscoelastic will come out, AC anterior chamber won't be stable. But then we have got 23 gauge micro rexus forceps that we can put inside through the side port. So that keeps the anterior chamber stable, and the same maneuver without introducing 26 gauge needle can be done.
Okay. Yeah.
One more thing I wanted to just check was, I have tried this needle aspiration quite a few times.
Manually?
Manually.
Yeah.
But I have also got a reverse Argentine flag in one of the cases where the nucleus is suddenly decompressed so much that from the visco pressure that thing has opened up inside. That also has happened.
That also you can get. See, the intumescent lens is a very funny. I mean, the Brazilians put out the theory about the intumescent lens. Why does it happen? It happens because with aging, you get this hydrolysis of the cortex, both anterior and posterior to the nucleus. And at the periphery, you get formed equatorial cortex. So you have two pressurized chambers. So when you decompress this chamber on top, without releasing this equatorial cortex, the pressure from the posterior chamber will push the nucleus up and it will form the Argentine flag. So you have to release everything. Having said that, not every case is like that.
Yeah.
There are children with hyperbolic cataracts. There's no nucleus. You just touch the lens,
And everything.
how it goes. So it's a very complex situation.
I've
You have to
tried
see.
many techniques. I've done a YAG lysis of the anterior capsule also
Yes.
before surgery. Phaco punch I've tried, but all that gives very ragged edges, which I find it difficult to clean up at the end. So now I've stuck to the double rexus protocol for
Double
all.
rexus is good. There's another thing called spiral rexus. What you do is you make a small rexus, have a small tag, and
Yeah.
keep spiraling it out. Because the theory behind this is very simple. You can control a small tag rather than a big flap. A big flap will run away. Small tab you can, but it's very time consuming. That you'll have to keep on putting visco and keep on going round and round. You can do that as well. But if somebody, if you see my video tomorrow, which I have, and you see the automated decompression, the technique, I can guarantee you will not do anything else after this. I don't do anything else after this now, because this is, I'm so much in control of the surgery. Double rexus, some, yeah, you do a small rexus, decompress the lens, but yeah, you do it bimanually? Ah, okay, some people use a Simcoe, some people do bimanually, you can do it. And I use my old joke, you know, all the techniques are fine, you can do whatever technique, nothing is 100%. The only thing that in life is 100% is death and taxes, nothing else.
As you told, when we were aspirating the cortical fluid, the 26 gauge needle, there was a reverse arginine flag sign. Okay, so we. Okay, might be. Yeah, because that aspirating, that is your technique, as you told, na, the both.
Hmm.
Yeah. It will start expanding. So actually that half minute, no, 30 second, it you have to very fast within seconds actually. What I think, but otherwise, yeah, it may happen. Okay, all the.
No, practically because you need to use a good visco at this
Yeah, exactly.
chondroitin sulfate.
Yeah.
That's a necessity, bare necessity. I use a micro. I start with the initial needle, but then I aspirate with a 2 ml syringe with our hydro cannula 27 gauge. I don't use a big cannula what we use 23 or 22, and then use a good micro rexus force. Everyone need to invest into a very good micro rexus force.
Yeah.
Don't ever open the main wound. You need to go from the side.
Side foot, yeah.
Because then you are in total control.
There's another paper which won in the ASCRS, I forget, I think it's from Karnataka. They have redesigned the needle. They've used a Sui needle, your sewing needle. Your sewing needle is not like our sutures, not like the needles we get. Our needles cut. It's like this, it cuts, so you get a linear cut. This is round body, so it makes a hole. There's nothing to extend. So they say with that, I mean, they say, I mean, I haven't used it, sorry. They're doing it with regular sewing needles, they get it done from somewhere, go in and aspirate. It doesn't extend.
Sir, in all intumescent cataracts, since there is no senior in my place, I routinely do a small rexus. So,
Yeah.
and with the visco cannula and 2 cc I aspirated. The small rexus, well punched one, is in your control. Once you aspirate the whole material, then do the double rexus. So not even a single case I get extensions since I started doing it.
I just told you there is nothing 100%.
It happens, but that's what I'm sharing my experience.
Yeah.
If you
No,
do
no.
a small rexus, aspirate that one with
Yeah.
the visco cannula and 2 cc and do a bigger rexus.
Yeah,
That's
this
a
is described.
perfect